feel like I used to feel.
I don't think I'd be where I am today had my own personal experience been so horrible.
This is the wrong group of women to piss off. Like, we have had it up to here.
Oh my gosh, wait, we're doing this wrong.
What would you recommend for anyone listening right now who absolutely knows something's not right? World-renowned menopause expert Dr. Mary Claire Haver is one of the most sought-after doctors on the planet, a best-selling author and a social media powerhouse with over 3 million rallying behind her mission to revolutionize healthcare for menopausal women. She's helping women navigate their hormonal changes with science-backed tools so they can advocate for their own health and happiness, proving to billions of women that while menopause is inevitable, suffering is not. So much to talk about. Myself, my team, digging into your work, into your books. There were so many things that just rocked me. One of them, in the US alone, 1/3 of women are peri or postmenopausal, and that most women will spend 30 years of our lives postmenopausal.
Exactly.
Let's just go right for it. Why is menopause such an important topic for women, and why have you chosen to make this your life's work?
I chose to make it my life's work because we have such a lack of education and knowledge amongst myself, amongst our healthcare providers, amongst the general population. And as a menopausal woman at 55 years of age, I am the healthiest I've ever been. But had I taken the road recommended to me by what the societies and you know, at the time that I went through menopause would have recommended, I would not be as healthy as I am today. And knowing that all of the changes that happen in our body in relation to menopause and knowing things that I can do to make my body healthier in response to this, I think is so critical because women are living longer than men. Great. But they're living that life in poorer health than a man. So we live 20% of our lifespan in poorer health than our male counterparts when we're age matched. And a lot of that has to do with menopause changes. And that is my focus. That's where I think the future of medicine should be, is keeping us healthy in this last third of our lives.
I loved in your book, you said I was a terrible menopause provider for years because there were huge gaps in my knowledge. And then you went on to tell the story about the WW, which I want you to tell. So let's talk about that. Like, in medical school, how did you spend most of your time? What were you learning and focusing on?
So medical school, you spend the first 2 years in what we call didactics. So book learning, physiology, you know, organ systems and, you know, anatomy, you know, and we're terrified. You know, we can't believe we're there. We all have imposter syndrome 100%. And 'cause it's very competitive to get in. And you're so stressed out that you've, you know, climbed this mountain and now you have another mountain to climb. But when I look back on what I learned in medical school about menopause in a 4-year curriculum, I think I got 1 hour of a lecture total.
Wow.
1 hour. So then in the US, I go to do my residency. I fall in love with obstetrics and gynecology, women's health, and I match at my top program. I'm so excited. I'm so proud of everything I learned in that program, but there was a huge gap. Menopause, I maybe got 6 hours total in a 4-year curriculum. And that level of education and focus had not changed. I was a residency program director in charge of curriculum. Like, we get a curriculum from the American Board of OB-GYN that we must check all these boxes, this many surgeries, this many hours doing X, Y, and Z. And I know at least until 2018 what was required of residents. And there was not like a menopause module or a menopause clinic requirement. You know, we got a few lectures throughout the 4 years, maybe 6 hours total.
Wow. And, you know, I heard you say on one of your IG posts, it's like so much of the emphasis was on helping women get pregnant and stay pregnant. And yet there are millions, if not billions of us who will never have children, myself included. And so it's just, as I was going through all of your work, it's like, oh my God, how are we here in 2024 and just talking about this? It's wild.
It took me losing my ability to reproduce to really realize where the gaps are in how we train and educate healthcare providers in this country. And that the focus on women's health is not the health of women. The focus on women's health is keeping her pregnant which is important. So much more than 50% of our training as obstetrician gynecologist is, so obstetrical training is pregnancy, right? Helping a woman through pregnancy, a very dangerous time of her life for some women, getting her through the process, delivering the baby safely, a little bit of postpartum care. That's probably 55, maybe 60% of our training in a 4-year curriculum. Then there's gynecology. And in that toolbox, open that up, we've got reproductive endocrinology, helping people get pregnant in general. We have GYN oncology, very, very important, cancers of the female reproductive tract. We have pediatric gynecology, how things in the gynecological world can affect a child that we need to be able to address, and a smattering of other things. And then there's menopause. And it just gets shoved in this tiny, tiny little box. Now, I finished my training in 2002, and that timing is important. Up until that time, we were being taught about hormone replacement therapy really only in the context of helping a woman with the most cliche symptoms of hot flashes and decreasing her risk of osteoporosis, and a little bit about genital urinary syndrome of menopause, just touching on it. But nothing about, I think I heard one, they brought in a guest speaker who talked about the cardiovascular system and menopause. And I was like, what? How's that related? We're here to deliver babies. And then the Women's Health Initiative results were dropped at the end of my training program in July of 2002. And that was it. I was the last class of residents who was classically trained in anything to do with hormone therapy.
So tell people who are unfamiliar with that particular, what dropped. What happened then? And then I definitely want to hit on that WW.
So finally, the National Institutes of Health was being headed by a woman. And under her guidance, which I think was magnificent, they decided, we knew for years that hormone therapy was helpful, for a multitude of things because of observational studies. We knew that women on hormone therapy had a lower risk of cardiovascular disease. We knew that women on hormone therapy had a lower all-cause mortality. We knew that women on hormone therapy had lower osteoporosis and lower UTIs and lower genital urinary syndrome of menopause. But it hadn't been proven. Correlation is not causation. How do you do that? A randomized controlled study with placebo. Okay, that is the gold standard. So finally, we're going to study aging women. We're going to study hormones. I mean, they're going to spend $1 billion on this study. This was amazing. So the outcome of the study was, does hormone replacement therapy truly prevent heart disease in a woman? So they recruited women between the ages of 50 and 79, but the average age was 62. The average age of menopause in the US is 51. So this is where things get important. So they start in 1998 and they recruit the women, and then they divide them into 2 groups, placebo, you get a fake pill, and no one knows who's in what group. They excluded women with hot flashes. Why? Because then they would know if they got the placebo or not, because it had to be double blinded. So if you give a woman estrogen, her hot flashes will decrease or probably subside. So they had to exclude those patients. So who suffers the most severely as far as health consequences for menopause are women who have severe hot flashes. So they're out of the study. So now we have women, we're down to and 85% of women have hot flashes. So now we're down to about 15%, average age of 62. Half of them get hormones, half of them get placebo. If you have a uterus, you're given estrogen plus progesterone, which is safe. And then if you didn't have a uterus through hysterectomy, then you were getting estrogen only. So off they go collecting data on these women. And what they see is there seems to be an increased risk of women who were in the non-placebo arm. They abruptly stop the study. They call a press conference, and before the findings were even fully analyzed, they released this data. And it was kind of the first viral thing I can remember before the internet, because it was this press conference. It was on Good Morning America. It was on all the morning news shows. It was on CNN. It was on everything, every which way. And in the newspapers, it was the #1 medical news story in 2002. Estrogen causes breast cancer. And it scared the doctors. We weren't allowed to read the study for weeks, months after that. It scared the doctors. It scared the people. 80% of women abruptly stopped their hormone therapy, threw it in the trash. Nancy Snyderman got on TV, who was a big medical reporter at the time, and, with the information she was given, rightly said, estrogen will kill women. We need to stop giving it in hormone. We need to stop giving hormone therapy to postmenopausal women. It's dangerous. And that message those findings have been mostly rescinded and in multiple papers, but that information has not been disseminated. And when you look at the American Board of OB-GYN, where I get my yearly recertification, we have to read a set of articles of latest research and then answer questions to make sure we read them. And then we get our little certificate. Okay, you're good for another year. There is almost never anything to do with menopause care. So here I am going through menopause, having horrific hot flashes, terrified to take hormone therapy because of my family history of cancer. But I'm like, you know what? I can't live like this. I have no option. I'm just going to have to take the risk because my quality of life is horrible. And, disrupted sleep. I didn't know my musculoskeletal pain at the time was, I'm just like your basic OB-GYN who's reluctantly going to try hormone therapy. And then I start reading and digging, and then I start researching because of the weight gain and the Galveston diet, how that all formed. More and more about menopause in general, and I'm seeing all these correlations between inflammation and cardiovascular disease, and I'm kind of remember something from my residency, what happened with that. And then I start meeting other doctors through social media who are really talking about menopause and presenting all these studies, and I'm like, oh my gosh, wait, we're doing this wrong. Like, this is really, really helpful. Not only, I'm just lucky that I didn't let myself menopause for too long, have those cliche symptoms for that long.
Yeah.
And someone asked me the other day, what if you would have been the 15% who really didn't notice much difference? Your period just stopped and you didn't have the hot flashes. I go, that terrifies me because I don't think I'd be where I am today in this menopause movement had my own personal experience been so horrible.
Isn't that so interesting? And I want to unpack that more when we get there. But
we'll talk about the WW. I forgot to.
Yeah, no, let's talk about that because I found it so startling, but not, to be quite honest with you. And if you can tell.
So in my OB-GYN training program, and I've talked to other doctors, and there's other terms that are very used across the country that are very similar. Wasn't just me. So we had gynecology clinic. And they would be a stack of about 80 charts every day. And there were upper levels and lower levels. So we have 4 years of training. So we had fourth year, it's very hierarchical. So the upper levels, they need their surgery numbers. So they're combing through the charts, trying to find the surgeries. And then everything left is like vaginal discharge, just kind of like nuts and bolts of different things. And then there's the WW in this gyne clinic. And I was like, what's that? And the upper level would be a tall Texan guy in his white coat with his cowboy boots walking down the hall. He's like, hey, you got a WW in room 4. Good luck with that. A WW stand for a whiny woman. And if she was Caucasian, it was a triple W, WWW.
A whiny white woman?
Mm-hmm.
Oh, wow.
Fun. And she had a constellation of symptoms that you couldn't put your finger on. Some hot flashes. She was gaining weight. Maybe some headaches. She was anxious. She was depressed. She was having brain fog. She was tired. And we were taught, it wasn't written in the textbooks. Don't get me wrong. My professors never said this. This was just kind of this
it's cultural
vibe.
Yep.
That was handed down. There's not much you're going to be able to do for her. Pat her on the knee. Tell her it's part of life. And we got to move on. We got to get to these surgeries.
Wow.
And that, I didn't think about that for a long time after my training. And I was reading something, researching something, and someone said whiny gyne. And that was another term used like on the East Coast. And I thought, oh my God, the WW, I forgot about that. Like when I think about the cultural perceptions, the kind of internalized misogyny that I had to confront in my own life and training, the, perception of what menopause really was. I didn't know enough at the time to say this is perimenopause or menopause. And that was a fact, that kind of thinking was still pervasive, is still pervasive today.
Yes.
It's less tolerated. It's not said as openly, but I think that line of thinking is going to take a generation to train out of our physicians.
If not more. And I think when you were talking about the internalized sense of it too, because I remember, I'm in my late 40s now, and in my mid 30s, I really started just paying attention to my numbers. And we'll talk about that. We want to get to, knowing your numbers because it's so important. And for a while, everything was just coming back pretty normal. It was like, okay, great. Everything's looking normal. Hormones levels looking normal, la, 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 la. And I just remember even starting to have conversations with my partner, like, I don't feel like I used to feel. And I love him and God bless him. He's like, well, you're putting a lot of pressure on yourself. I'm like, yeah, but that's not new. Like, you know, like this isn't new. And so it's been like probably over the past decade or so, where I keep feeling, I'm like, something's not okay. Like something's different, something's not okay. And I have so many friends in the industry and I feel like I'm a fairly good communicator. And I cannot tell you how much internally I've been like, oh, well, this must be a part of getting old. Oh, well, you must not be as strong as you used to be. Like all of this kind of self-punishing internal dialogue that I didn't grant myself necessarily the possibility to go like, well, how much of this is actually chemical? How much of what's happening for me, and is there help out there? So that's why I wanted to talk about that, because it's like from a cultural perspective in the medical system and our internalized versions of that as women, especially as ambitious women, which we have a lot of those folks who pay attention, listen to our show. They're entrepreneurs, they're creators, they're taking care of everyone and everything and have been for decades. And now you get to a point in your life where you're in your late 30s or 40s or 50s, not only are you taking care of aging parents and a business and your family, and now your own health, the wheels start coming off.
Right. And it's so interesting you say that, because that is kind of universal when I sit across the desk from my patients, and they are recounting. I'm like, tell me the last time everything was okay when you have you increased stress in your life? No, I've managed this machine for years. When I started researching for the new menopause, I would read these articles and it would be a woman can have, all these symptoms, but this is a terrible time in her life. She's doing all the things you said, the aging parents, the whatever. And by the time I got to the 15th article where they were putting psychological, taking physical symptoms and assigning it a psychological reason, I threw the paper down. I said, enough is enough. This latest article from The Lancet that was published, in March, again, talked about, oh, but this is a tough time in a woman's life. And I think we're totally doing a disservice. Of course it is. But these are things that we have managed forever, and not allowing even the thought that the hormonal milieu that is changing inside of our bodies is affecting our ability to cope, I think is completely doing a disservice to women.
I was thinking about that this morning when I was preparing so we could have this conversation. And it was really fun. I'm walking around with my coffee. I'm like, knowing myself and knowing my group of friends in this kind of age range, late 30s, 40s, 50s, I'm like, this is the wrong group of women to piss off. Like, we have had it up to here. We're exhausted. We don't have the resiliency. Like I'll just speak for myself. I'm like, can't take it. Do you know what I mean? It's like not one more thing. So I just found myself cheering at so many of, and for those of you who don't follow Dr. Mary on Instagram, you have to, because your shares are incredible. But it's like, there are chemical reasons for how you're feeling right now, and you don't have to suffer. I heard you
don't have to do with an intrinsic psychologic process.
Yes. And you're not getting weak, and you're not just quote unquote, everyone's getting older. And I want to get to some of the things, like some of the distinctions between chronological age and endocrinological age in a little bit. But I heard you talk to about estrogen deprivation. So how do we know we might be experiencing this? And also, if you can just walk us through those 3 phases of perimenopause, menopause, and postmenopause, just because most of us have had no education on this whatsoever.
Sure. So the best place to start when we talk about the phases of menopause is to start embryologically. Females and males are very different in as far as our sex hormone production and our gonads are. So, females have ovaries, males have testes. Everybody realizes that. But what most of us don't know, humans don't know, is we're born with all of our eggs. They form when we're 5 months in utero. They finish forming inside of our mothers, and we start losing them from that point. So we lose the amount and we lose the quality.
Wow.
Okay.
I never heard that before.
By the time we're born, we have about 1 to 2 million eggs. That's got to last us as long as they last. By the time we're 30, so we start ovulating. Each month we lose about 11,000. Okay. And we lose some as children while we're children. Then we're not ovulating yet. Then we go through puberty and we begin the ovulation process if we're healthy. Then at about age 30, we are down to 10% of our egg supply. And by the age of 40, we are down to 3%. Menopause is complete senescence of that ability to ovulate. We've basically run out of eggs that are functional, and they're not coming back. And so when you think of it that way, you're like, oh, so we're cruising along in our 20s. Everything's going right. Our hormones look like an EKG, basically. We have this rise of estrogen mid-cycle. Then that's followed by a rise in progesterone that drops off. When estrogen rises, we thicken up the lining of the uterus, and then the progesterone decidualizes it, kind of coils the blood vessels inside of those glands, and then they shed when the progesterone drops off. And the whole thing starts over again each month in preparation for pregnancy. That's what, on an evolutionary basis, that's why it's there. Whereas males make their stuff fresh every day until they die, usually. It gets harder for them to propagate children, but they can do it, if they try hard enough. Mm-hmm. So menopause represents, from a medical standpoint, it's defined as 1 year after the last menstrual period. Mm-hmm. Easy kind of pinning that tail on that donkey's pretty easy. What it represents is the loss of the production of estradiol and progesterone from the ovaries and some testosterone from the ovaries, okay? So the disruption in the force, so we're going along each month. As we reach some kind of critical level of egg quality and egg quantity, that process starts going awry. We end up in a zone of chaos, and that's perimenopause. And it's about 7 to 10 years. So the brain, the hypothalamus, the gland in the brain, is constantly testing the blood, has a little monitor inside, some little chemicals, that's checking for estrogen levels. And when it sees that they're low, it gives out a signal called GnRH to the pituitary gland to say, again in the brain, tell the ovaries to get working. We need more estrogen. So the pituitary makes something called luteinizing hormone and follicular stimulating hormone, LH and FSH, which basically talk to the ovary, bind to the ovary, to the thecal lutein cells around those eggs, and say, produce estrogen, testosterone, and then finally progesterone after ovulation. Estrogen levels go up, the brain quiets down, we're happy, we're good, okay? But when the egg quality drops and the number of eggs drop, that gets harder and harder. The ovary can't respond like it used to. So the brain's like, hey, step it up. I need more. Then you get surges of these hormones that say, ovary, get in gear, let's do this. And you get these loop ovulations, these late ovulations where you'll have these massive dumps of LH and FSH, where then finally you get this boom production of estrogen. We see in perimenopause these dramatic highs and lows of estradiol production, followed by kind of progesterone. And that's the zone of chaos. So in perimenopause, remember, we have estrogen receptors all over our body. And most women are like, something's not right. Mm-hmm. It could be brain fog. It could be mental health changes. We know pinning the tail on the easy donkey is period disruption. And that period disruption could look like anything. Too heavy, too light, too regular, not regular. They're missing. They're coming too soon. They're so heavy, I can't stand it. I'm anemic. They're so light, I can't find them anymore. So it's called dysfunctional uterine bleeding. And it could look like absolutely anything. Right. 90% of us will have dysfunctional uterine bleeding on our path to menopause. So musculoskeletal symptoms, your gut microbiome completely changes. How you process glucose changes. Your lipids change. I mean, there's not an organ system or a metabolic function that is left unchanged from this very natural process. Yes. So how that is expressed in our bodies is different from woman to woman. And we're not training our healthcare providers about perimenopause at all or how to recognize it. They know menopause. No more periods, we're done. Right. But they're not seeing the huge picture of the metabolic changes, cardiovascular changes.
7 to 10 years is so big. And I'm just thinking to myself, like, I'm just kind of tracing back over the past, let's say 6 or 7 years. And I can, again, even hear internally kind of my own bias and going, oh, no, not yet. And feeling the same experiences of anxiety and depression that I had never experienced in my life. And I've talked about this on the show before, that honestly, Mary, it was scary. Mm-hmm. Like, I was experiencing my own life in such darkness that I knew from a logical perspective, there was no reason for it. Like, on paper, I was like, shit's good. Like, business good. I have great, like, right. Nothing made sense.
So imagine if you, somewhere in your 30s, you go in for your annual visit and your doctor screened you for those things and gave you a little bit of education around what might happen.
Yes.
So that you weren't so petrified when this constellation of symptoms lined up.
Yes.
That you knew this might be perimenopause. Let me go in and talk to my doctor again. I might need some other tests to rule out autoimmune disease or hypothyroidism because a lot of things have overlapping symptoms.
Yep.
How different would your experience have been?
Oh my gosh. I mean, enormously different. And, my journey kind of progressed to where, and I may be getting these terms wrong, but I'm just going to explain it from my own internal perspective, where I started having so much physical pain in my body. And this was during the pandemic, that my best friend who lives peacefully with cancer, she's like, you need to go get this checked out. And I'm like, there's no way. No, I'm fine. And finally we discovered that I had all of these enormous tumors growing outside of my uterus. Like one was the size of a grapefruit and it was just a mess. And I opted to, they said, exactly. So they left my ovaries intact, but it was not a fun thing. And it was just, and then that kind of sent me on this journey, which I wanted to talk to you about. A friend of mine, checked in on me and she's like, have you done a Dutch test? I'm super curious to hear your, and it was just, I had done all this blood work before and it was like hormone stable. She's like, yeah, now it's really important. We really have to keep an eye on this so that you can feel the best that you can feel. And I was like, why are we not talking with women in their 20s and 30s to start understanding their baseline of how they feel their strongest and their best? And I know not everyone feels their strongest and best, but still just to have some type of baseline so that when we start to enter, what did you call it, of chaos?
The zone of
chaos, where I'm like, oh my God, I've been living in the zone of chaos. So many of my friends too, we talk about like, what the hell is going on?
So do you know that there's a disruption of blood flow to the ovary after hysterectomy? Now, hysterectomies are needed, Were you counseled that you would go through menopause 3 to 4 years sooner than you would have naturally?
No.
Yeah. To be on the lookout for those things?
Yeah,
to be
no,
aware.
absolutely not.
So now you're, average age is 51, normal's 45 to 55. We
Yeah.
have to back all of that up 4 years for you?
Yeah. Yeah, no, it was like, okay. And it's like, well, mostly the conversation was around whether or not I felt like, it was like, are you sure you don't want to have kids? And I've always been sure since I was born. I was like, that's not my path in life. And so I was like, from that point of view, but it didn't go far beyond that, if I'm just going to be really honest. And so, yeah. And so now it's like, we'll talk offline, but it's like, okay, well, all of these other things, I just went through this whole gastro thing and I'm like, okay, getting that back online, but it's like it feels like another full-time job to keep myself in my strongest, healthiest state in addition to all the other stuff. And I'm like, no wonder women are frustrated and exhausted and like, can't do this.
Right.
Tell me your opinion or just your thoughts about, because we have to start knowing our numbers. And one of the things that I think has been so frustrating for me, and I don't know if the test really exists because it's a moving target.
Right.
You're talking about with men.
So that's part of the problem that, medicine loves a blood test.
Yeah.
A doctor loves a blood test. Yes or no? Check the box.
Yeah.
And because of this chaotic fluctuation, we don't have a one-time blood, urine, or saliva test that is clearly therapeutic, diagnostic rather, of being able to diagnose the perimenopause transition. Right now, it is a literal diagnosis of exclusion. One, the doctor needs to know that it's a thing.
Yeah.
And needs to know the group of symptoms that it might be. There's been a scoring system around, a symptom scoring system that has nothing to do with your periods. They never even ask about your periods. It's all about mental health changes, gastrointestinal changes, skin changes, general urinary changes, and the likelihood that this is related to perimenopause, and it's validated. It's been out since 2008. I'd never heard of it until I dug into the research.
Wow.
I now use it in my clinic, but someone who's menopause educated should be able to tell if you're perimenopause with a conversation. Blood work, I do extensive blood work, but I'm ruling out those other conditions, nutritional deficiencies, looking for inflammation markers, because in my clinic, it's a 360,
Yes.
We do nutritional counseling, exercise, I cover everything. And of course, hormones, whether or not she wants hormone therapy is part of that conversation, but it's that big.
Yeah.
What
did you experience personally? Like, did you have an experience with perimenopause where you started feeling that zone of...
Not so much.
Not so much.
I had polycystic ovarian syndrome. So I had an endocrinological disorder. I'd had my whole reproductive life. That's why I had fertility treatments to have my children. And in order to mask that, I couldn't lose weight because I was already thin. I had thin PCOS, and that's a tougher nut, At the time, treatment was really diet, which I had covered, and then to suppress, the hormones with birth control pills, which worked really well for me. I know they don't work for everyone, but I did really, really well on them. So I was cruising along in my 40s and I would just skip my periods. I would just continuously, I didn't know that I was treating my perimenopause at the time. And so at about age 48, I decided, okay, I talked to my practitioner and we said, let's get off the pill and see where you are. Well, if you're skipping still, because I was PCOS, I didn't have regular periods. We'll check your hormones and see if you're fully menopausal yet. So I stopped taking them. And at the exact same time, my brother, Bob, this was 2015, he had been ill for a long time. He had end-stage liver failure from HIV. And he got really sick, got hospitalized with a stroke. So I rushed home. We ended up doing his end of life care. And then, spent 2 weeks at home grieving, helping him towards his death and then grieving and then having to go right back to work. Cause you know how much time we get off for bereavement. Like
nothing.
They gave me a week. And so of course, did I get therapy? No. Did I do counseling? No. Did I do anything other than just go back to work and try to cope? Yes. I wasn't taking the pills anymore. So I'm attributing all of the symptoms I'm having to grief, which probably was contributing, definitely. I wasn't sleeping. I was having horrific hot flashes, horrible joint pain. My nutritional went out the window. I was just coping. I was in survival mode. I was filling myself with processed carbohydrates as a way to numb the pain.
Yep.
I would cry the whole way. I'd go to the work, be the best doctor, cry the 40-minute drive home, cathartic, get home, stuff my face with my kids' goldfish crackers, and then start making dinner and try to be a good mom and wife. And so through that process, didn't realize I was in menopause. And then finally, when the grief started lifting, I realized, wait, when was my last period? Wait, why am I not sleeping? Wait, these are hot flashes. I was like, oh my God, I'm menopausal. I gaslit myself. This was my job. And so I reluctantly have a conversation with my practitioner. I think I need hormones. I can't live like this. I'm not sleeping. And she's like, we really worry about breast cancer with your family because I've lost a brother to leukemia and another one to esophageal cancer. Well, he had been diagnosed by then. So and I have all of my mother's family and all of my father's family have had cancer, 90% of them. And, I didn't know that the WHI findings had been rescinded. I didn't know, no one had put those articles in front of me as part of my continuing medical education. And I didn't know enough to dig and look. So I reluctantly decided to start hormone therapy. So I really was truly, without estrogen for 6 months maybe. Mm-hmm. So then I'm also dealing with the weight gain from not doing exercise and nutrition. And I decide, okay, girl, get back to your, usual workout habits, work out less, eat more, which is what I told my patient for 20 years. And it wasn't working. It didn't work for me anymore. And I was like, it has to. I couldn't have been lying to these patients all these years. So I'm calorically restricting to, I think, 900 calories a day. I mean, it had to work. Yeah. I'm doubling down in my home gym. Nothing. I mean, I'd lose a little bit and then it just bounce right back on. All the tricks that I was doing to get back into my jeans, after babies and all that. Not working. So that's when I was my husband was going on a trip and I was like, when you get back, you're going to have the wife you deserve. And he's like, babe, I love you. This is crazy talk. You look great. I don't care about whatever you're worried about, but your daughters are watching. I had 2 girls who were teenagers at the time. They're watching you disparage the way you look. They're watching you I was the almond mom at that point. I was doing all these crazy eating behaviors, showing them negative self-talk in front of them, all the bad things. And it really was sobering for me. So being a type A physician, decided all right, I'm going to fix this. And he's like, you're smart. Figure this out. It's not working. You got to do something different. What do you tell the kids? When the behaviors you have are not working, you must change your behavior. And okay. So I called the nutrition scientist at the university I was employed at and was like, what is going on in menopause? Why are me and all my patients at this age? Because remember, I'm aging with my patients.
Yes.
And we're all complaining of the same thing. My girlfriends and, we're marathon runners. We're super healthy. We're fit. I'm finally getting back into those habits and I don't look the same, which is distressing me. I wasn't thinking about the cardiovascular disease risk and all the other stuff that was happening inside of me. I just didn't like how I looked in clothes.
Yeah, dude, we're vain. That's
totally
normal. Yes, come on.
And so they start pointing me in the line of all this research on nutrition and inflammation, and then menopause and inflammation. And this is all new stuff. And I'm like, oh my God. Okay. I dug into fasting, Mark Mattson's research. So then everything when I first put a toe in the water for menopause was really about weight gain. Mm-hmm. Talking about that on social media. And then all of a sudden, like, women are like, what? Wait, I'm not lazy. I'm not crazy. I'm like, no, this is a thing. And so that's where my social media presence started really growing, is like the open conversations I was having with my own struggles, hormone therapy. And then I'm learning about, whoa, these studies, well, isn't it dangerous? Not really. Actually, these studies have been rescinded. I'm making friends with other menopause doctors online. They're sharing articles with me. Then my menopause window got a lot bigger because I'm growing, and people are asking more and more questions, not about weight gain, about frozen shoulder, about palpitations, about musculoskeletal pain, about frozen shoulder, about, could this be related? And when 10,000 women ask you the same question, I'm curious. So I start digging into the literature instead of saying, no, can't be that, and realize menopause is much bigger than we thought. Sure, nutrition is important. It's probably the most important thing for our overall long-term health. Mm-hmm. And some nutritional changes will likely affect like how many hot flashes you have. But like this is way bigger than just stamping out a pesky hot flash.
I have to say this. So for everyone, this book, I feel like it's like the menopause Bible. That's how I felt.
You said it. I did not.
Well, when I was reading this, because I'm like, I'm finally getting the education that I didn't know I needed. And I think one of the things that's so brilliant that you've done is the entire big toolkit, which is kind of the back half of the book. It's like, hey, if you have any of these dozens and dozens and dozens and dozens of potential symptoms, here are evidence-based ideas, strategies that you can try to help alleviate outside of what's it called? I always want to call it HRT because that's
pharmacology.
Yes, exactly.
We talk about pharmacological ways that you can adjust to these symptoms, but the big six of what I call the visceral fat, the cardiovascular, the cholesterol, the things that are going to mess you up later on.
Yep.
Are mostly, HRT does have a definite, it gives you an advantage there, but it's not going to take care of your nutrition. It's not going to take care of your movement for you. Those are all important.
Yes. Okay. So I'm curious to hear from you personally. Are you still doing HRT? And what was that like for you?
I'll probably die with an estradiol patch on.
Yeah. My mom actually, one of the reasons it was interesting, like every woman on my mom's side of the family had hysterectomies. And I remember my mom was the one, she had it. And I felt like when you were telling the story about when you were in training and it was like looking for the surgeries, this was like in the 80s. And it felt like when women were getting hysterectomies, like they were just like, you need one
time.
And you need one. Everyone needs one,
time.
Right?
You don't need that anymore.
Right.
And we're removing people's organs.
Right. And so I remember distinctly, it's like, when a memory in your family gets burned in your brain of my mom, like moaning and wailing in so much pain. And she was so angry. It actually stopped her from going to the doctor for like 30 years. We still have her. I almost lost her a few times last year. That's a whole other story. But I remember she went on estrogen and she told me, she was like, changed my life. It changed her life. And so we had never really had the conversation again. That was a conversation I think I had with her in my late teens, but not now. And so what was your experience? Did it take a few months for you to start experiencing, like, what was it like?
So the hot flashes, I remember like at week 2 thinking, is this going to work? Is this going to work? Is this going to work? Then all of a sudden by like week 3.5, by week 4, I was sleeping through the night every night.
Wow.
And, waking up like Cinderella, like, and the rainbow and the birds chirping and like being like, oh my God.
I can just hear so many women in the audience crying now. You know what I mean? Just like, is that possible again?
And again, because I have a uterus still,
yes,
I had to have progesterone.
Yep.
I didn't start testosterone until probably 6 months ago. And I'm also using topical estrogen. So I replaced my hormones right now 4 ways. So I'm doing systemic estrogen for the cardiovascular benefits, of course, for the symptom reduction, for the cognitive benefits. You know, I happen to get there in the right window of opportunity for both cardiovascular and neuroprotection. I'm doing it to protect my bones, and I'm doing it to protect my genitourinary system.
Let's talk about that. What is that window of opportunity, especially for cognitive function? Because I think, again, I know part of the reason that folks listen to me is I have the same kind of flavors crazy as many of them do. We're ambitious and we've got lots of stuff that we want to do. And the moment for me, I get really frustrated with me if I don't feel the level of sharpness that I have been accustomed to for most of my life. It's really hard. So what is that window?
Most women will have some degree, and for a large amount of us, a significant degree of decrease of cognition. The brain is rewiring through this senescence time period. Estrogen is very, very, very active in the brain. Progesterone's active in the brain, and turns out testosterone is likely active for women. Well, for all humans, you know, we all have the same 3 hormones, by the way. We just have them in different levels. And so, if you look at Lisa Mosconi's work, and her book, The Menopause Brain, is fantastic. Highly recommend read, especially if you have Alzheimer's and dementia in your family, you know, and you're worried. She's got some great strategies, also highly nutrition-based, on ways that you can decrease your risk. But anyway, but just to let your listeners know, this is expected. This is going to happen. And it doesn't necessarily signal the path to dementia. Most of it will eventually return if you're not on the dementia pathway. But, you know, remember that Alzheimer's is a disease that begins in midlife, that we don't have symptoms until we're older. These processes are starting now for us. And when we look at the WHI data, when we look at the SWAN studies and these big, big databases where women were studied, it looks like for certain, the older you are at menopause, naturally, the less your risk of cognitive disorders is as you age. Estrogen is very protective in the brain. The earlier you go through menopause, the more likely you are. Now, it's not a one-to-one correlation at all. You know, women who have premature menopause don't automatically go and have dementia, but they're higher risk, okay? So, great study out of the British Medical Journal. First time I've seen data on estrogen presented this way. They looked at lifetime exposure to estrogen, both natural and HRT. So age of menopause minus puberty, plus any years that she had on hormone therapy, and the risk of cognitive disorders with that. And it was pretty much a correlation. The longer you're exposed to estrogen, the lower your risk of cognitive disorders.
That's amazing.
Yeah, of dementia.
That's amazing.
So, and I'm like, that's out of a database. So that's data that's been sitting around. Someone just pulled the numbers. Let's do that for blood pressure.
Yes.
Let's do that for cholesterol. Let's do that for cardiovascular disease and look at it that way. So starting HRT within at least the first 5 years of your seems to be protective for both Alzheimer's and for other forms of neurodementia. So
that's incredible. You know, when I had my hysterectomy, and then I just started feeling really nervous, to be quite honest with you, because I didn't know who I can trust.
Yeah.
And it just felt like it was like, I don't know, and I started talking with girlfriends, of course, and I feel like I have a little bit of an advantage because based on what I do, I get to talk with really smart people like you. So I have a network of smart docs who I can start reaching out to. What would you recommend for anyone listening right now who absolutely knows in her heart something's not right? It's going off the rails and is perhaps, whether her doctor, for whatever reason, she doesn't feel a high degree of trust.
Right.
That this is the right person. Where can she start to look? It is
not reasonable, and I think it's terrible that you can expect to go into your lovely, trusted OB-GYN who delivered your babies and has done your contraceptive management and whatever else you needed to be menopause informed. I was that doctor. I did my best with what I knew, but I did not nearly know enough. So it's finding someone who is menopause informed, and it might be an internal medicine doctor, it could be a family medicine doctor, it could be an OB-GYN. So one place to try is the Menopause Society has a certification process. Right now, there's only 1,200 of us trying to take care of every menopausal person in the world. And you don't have to be an OB-GYN to get menopause certified. So that's one place, and it's still not a guarantee.
And that's something people can Google.
Yeah, you can look up, you can go to menopause.org and look up now. And they only certify twice a year. So there's another crop coming out in June. So we're getting there. There is on my website, I have testimonials from patients all over the world who have said, look, I found someone who was amazing. And so we have that information kind of consolidated into a database on our website. That's another place. Call ahead.
Call ahead.
Ask.
Yes. What should the questions be? Because I feel like for me, even though, again, I consider myself a fairly good communicator, not having either scripts or the questions to ask, or if there's any kind of red flags, things, because I'll tell you my experience.
Will the doctor
yes, please
have a conversation with me about the risks and benefits of hormone therapy to treat my menopause?
Say that one more time.
Will the doctor be willing to have a conversation with me about the risks and benefits of hormone therapy to treat my menopause?
And if it's anything but a yes, we keep on moving.
That's it. Not every woman will choose it.
Yep.
Not every woman is a candidate, but 100% of us need the conversation and the education.
Yes. So, there's different forms of HRT. Can you walk us through some of those options?
So we look at the formulations, so the types of hormones. So the human body for sex hormones makes estrogens, makes progesterone, and makes androgens. Those are the, I call it male type. We all have them, okay? Estrogens are estradiol. That's what our ovaries make. That's the one most of us know. Estrone is a weaker estrogen. It's produced in fat cells in peripheral conversion and different cells, usually fat cells. And the precursors usually start in the adrenal gland there. And we make androgens both in the ovary and in the adrenal, through the adrenal pathways as well. When we talk about hormone therapy, in general, we're talking about estrogen. Most of the research, the studies, the emphasis is on estrogen. We give progesterone to protect the lining of the uterus from unopposed estrogen. So if you have a uterus, you must take a progestogen, mandatory.
What if you're people like me who don't?
So it's optional, but I'll tell you why I recommend it.
Okay.
And then there's androgens, which would mostly testosterone is what most people would understand. So in traditional HRT, it's estrogen based. And when we talk about risk benefit and cancer, it's usually the conversations around estrogen plus or minus the progestin. So in the WHI study, which they only looked at Premarin plus or minus Provera, which is conjugated equine estrogens, and medroxyprogesterone acetate. That was the only formulations they studied, which was not unreasonable because that was the number one prescribed product on the market. Other stuff was available, but harder to get, or and Premarin was part of the study. They paid, so here, use our drug.
Yep.
Okay. So turns out that the estrogen only arm, the women who had hysterectomies, who only got estrogen, had a 30% decreased risk of breast cancer and a higher survival if they did get it.
Wow.
Yeah. And when they reanalyzed the data, there was it was only the estrogen plus progesterone arm, and it was a 0.8% per year absolute risk.
Wow.
What got reported was the relative risk. It went from, and I hope I get the numbers right, like 5 out of 1,000 per year to 6 out of 1,000 per year. 5 out of 1,000 per year was the baseline risk, placebo. Mm-hmm. Women get breast cancer because they have breasts.
Yes.
Okay, that are active and have a lot of, glands in them. And then that went to, so a 25% increase of relative risk. So a lot of people don't understand statistics. I really have to put on my thinking cap when I think about it. But that's a relative population risk versus an absolute risk of what is my risk. So I'll have one extra case per 1,000 per year if I take this hormone therapy. And even then there's some debate over if that's actually accurate. So, it's much, much less. But we took that option of that discussion away from women, which I think is outrageous.
Absolutely. It is outrageous.
There was no longer shared decision-making. It was a no. Chin up, Buttercup. We're only going to give this to you if you're suffering severely from the cliche symptoms and only for the shortest time possible.
You would think even from an economic perspective, and listen, I'm a person who loves money and I believe in capitalism and I like all of that. It was like, you would think that our society from a pure productivity, economic GOP perspective,
it's like cost savings,
yes,
polypharmacy for, Celebrex to treat your muscle and joint pain. A cholesterol statin. Let me talk about statins. I'm going to blow your mind here in a minute. Statin, an anti-anxiety, an antidepressant. So let's look at absolute numbers. So another thing that there's been this talk of over-medicalization of menopause. It's not a disease. Why are we putting all these people on? That is the most misogynistic, paternalistic, horrible thing I've ever heard. 5% of women in the U.S. right now are on hormone therapy who could be on it, menopausal women. Yet 25%, 20%, if we go from 10 on SSRIs to 20 through the menopause transition, we double. And then that goes up to 25 by age 60. The world is fine with that. That's not over-medicalization. 1 out of 4 women is on an SSRI. But probably we would have lessened that risk of her developing a mental health issue if we would have had her on hormone therapy. So like we can just give her, oral estradiol is $3, by the way. So when we look at the economic impact of, plus they're quitting their jobs.
Yes. That's where I was going with it.
They're leaving teaching positions, nursing positions, those traditional female jobs at the height of their careers. And who's suffering? Us.
Yes. All of
patients and students.
The wisdom that we're losing,
right.
The experience that we're losing, the leadership that we're losing. Because understandably, women are, again, it's like you want to put your fucking head through a wall because you're like, I cannot take this.
The loss of confidence. I mean, I say this and I don't say it lightly. I have an hour with a new patient who comes in. And she fills out a huge questionnaire. We do mental health screening, before she gets to the door. We do a validated menopause score. We do a sexual desire score, sexual function score, all of that. So I know all that before she hits the door. It takes her 20 to 30 minutes to unpack her menopause trauma. And for me to validate her that she's not crazy, and then we launch into therapeutic options.
I believe it because we have so much backlog of being dismissed and just told, nope.
There's nothing you can do.
There's nothing you can do.
You're just getting older. And that's true. You are getting older.
Yes. And I thought that there was something just fascinating that I read. It was the rate at which our ovaries age is twice as fast as for every other organ system in the body.
Yeah.
I had never heard that before. Yeah. And it's like, so this is real
versus
chronological aging.
Chronologic aging.
Yeah. And so we need to handle this.
And it doesn't really happen. Men have some senescence of but it's like a 1% decline each year. It's not the chaotic,
the zone of
drama
chaos
of perimenopause and then dropping to less than 1%.
Yeah.
It's very different.
So let me go here with you for a minute because I loved in the book, there's a lot of sections about knowing your numbers. And again, I feel like these past few years for me, I'm like, this is another full-time job of understanding my biometrics, of understanding from a personalized medicine standpoint, all the things I need to do to keep this thing running tight and right and cute and strong and healthy and all that. What are because again, you're very comprehensive in here, but if a woman wants to start keeping an eye and knowing her numbers, can you give us any top lines of some of the kind of top tests? And again, we know about bone densities. There's going to be a whole range of things. Cholesterol.
You need to know your cholesterol because it's going to rise. If you eat with no changes in diet and exercise, the loss of estrogen will change the way that your liver processes, and you will end up with a lower HDL and a higher LDL, a less favorable lipid profile that is more likely to contribute to future cardiac disease.
And how about in terms of hormone testing as it is? I know we kind of were talking about that for a minute, but I don't know if I ever got really clear of your viewpoint on the Dutch or what we can do.
I don't use the Dutch test. I don't find it helpful.
Okay.
I don't really do much hormone testing unless if she's had a hysterectomy or an ablation or has a Mirena IUD and I can't use her periods as a guide, then I'm kind of checking FSH and estradiol. If a patient comes in and we are struggling to get her therapeutic on her medication, I'm worried she's not absorbing, I'll send in estradiol. There's some interesting new data coming out looking at risk of hyperlipidemia and checking FSH levels. FSH, remember, is that hormone that the brain says, hey, give me more.
Yes.
Using FSH to track if she's truly getting enough estrogen to get her cholesterol in check. So really exciting new data to come with that. So I'm starting to send a few of those whose cholesterol's, like their hot flashes are gone, but we're struggling to get her cholesterol down. And so I'm experimenting with that with my patients. And she understands that we're just kind of throwing stuff at the wall right now.
Yeah.
So we're still kind of, again, another zone of chaos is treatment is, we don't have therapeutic ranges established. They look like they might be different for different people, meaning if my level's 50 and I'm feeling great, my hot flashes are in check, my cholesterol's in check, all the things, everything's kind of running back to the normal aging process. But your level's 50 and you're in the gutter still.
Yep.
Nothing's better.
Yep.
So we don't have, those might vary from person to person. So we don't really know what your therapeutic level is going to be. And remember, I can't say let's get a baseline at 25 because it's an EKG each month. We have our baseline. We surge with ovulation. It goes back to baseline. So we don't really know what those levels are going to be. So like if someone has premature menopause, I know I want to get her up to 100. We've kind of established that. Those are pre-menopausal levels. But no one is suggesting in postmenopause that we go to pre-menopausal levels. It's almost that same kind of like, no, we want to give her just enough to keep the hot flashes at bay. But is that the best thing? Is that really going to keep her as healthy as possible? We don't know yet. That's where the research needs to come in.
It's fascinating. And I'm so happy that we're having this conversation because even for me personally, it's helping me set myself at ease. I'm as a type A person, I like control. I like clarity. I like specificity. And this is part of what's been so utterly frustrating for me. I'm like, well, just, for me, it's like, tell me a target to hit. I can hit it. You know what I mean? Give me something to go for.
Give me a checkbox.
Give me a checkbox. Tell me what I need to do, and then I'll do it. And just this conversation alone, just understanding like, okay, so we don't have tests to know the numbers per se. We're only just starting to throw some spaghetti at the wall. And it is so individualized, which makes it critical that you're working with a provider or someone that can be with you on this journey so that you can keep reporting back, right? And keep testing and looking at cholesterol level. Let's talk about bone density for a moment because I loved when I saw on your IG, I love working out. So I was a former Nike Elite dance athlete. Fitness has been a huge part of my life and I've been having so much fun in these last 6 months. I've got some good guns, right? Listen, I'm Jersey. It's like the gun show, Jersey Shore. It's like, come on. Anywho, strength training.
Yeah.
One of the most important things we can do. Let's talk about that.
Yeah. So, I have this talk that I give about what I would tell my 35-year-old self. And nutrition over calories and strong over skinny are like the top two things. I was a cardio queen. I was running marathons with my girlfriends. Everything was about looking a certain way. I knew skinny was fit, and there's, thinner people do tend to be a bit healthier, but like this relentless focus on staying thin, and that somehow gave me a health advantage. It's better than obesity, but I was chipping away at my bone and muscle strength, only focusing on cardio. Women didn't lift weights. That was not a thing when I grew up, not in general. And the ones who did, I was like, what's she doing in the gym? I don't know. I was on the cardio machines. Right. That is so wrong. We reach our maximum naturally. Our natural peaks in both bone and muscle strength are usually in our 20s or 30s, and we begin the aging decline. But for women, or those of us born with ovaries, that starts accelerating that muscle and bone loss through the menopause transition. And part of the reason why we gain weight and we change our body composition is estrogen declines, we lose muscle by the bucket at that point, and we're losing bone strength, but muscle is what determines our basal metabolic rate.
Yes.
So the rate at which we burn calories depressed. So no changes in diet and exercise. You're losing muscle. You're gaining fat. And estrogen is great at driving fat to the hips and thighs and that pear shape, the female. We start driving fat like men do to the abdomen and the abdominal cavity. And that fat represents increasing inflammation, increasing risk of cardiovascular disease, diabetes, stroke. And so to stop defining health so much as terms of just being a thin person, you want to be a strong person.
100%. And it feels so good. I've always felt like it's like the best pharmacy that I have access to, you know, my best own natural pharmacy. And it's amazing. I'll say, like, I have gained so much strength in the past 6 months, where I used to, again, I would always complain to Josh, my partner. I'll be like, I'm not as strong as I used to. He's like, you always say that. I'm like, no, it's true. But now, as I'm like throwing up weight.
You can gain muscle at any age. It's harder.
But it feels fantastic.
So I started testosterone because I have a body scanner in my office where I can measure muscle mass and visceral fat. And that guides my counseling as far as nutrition and exercise for patients. And I have low muscle mass. And I still had low muscle mass, and I still had low muscle mass. And so I realized that I'm not eating enough protein and I am not doing enough lifting.
Yeah.
So I started fixing that. And I'm like, as it stands today, medicine has only recognized that hypoactive, that testosterone is helpful for menopausal women for hypoactive sexual desire disorder. But we have a lot of observational studies that suggest it's great for bone strength. It's great for muscle strength. It's great for cognition. It's great. We have testosterone receptors everywhere in the body. And the people who focus on sexual medicine are like, listen, we can't ignore this. We need to do more studies on this.
Yes.
So I started it for muscle mass. And it's helping. I've put on a couple pounds of muscle, so yay me.
Yeah.
Definite I did not think I had a desire issue. We were fine. No one complained at my house. Everybody was okay with sexual desire.
Yeah.
Definitely an uptick in the area.
Really?
Did not expect. I knew we treated people for that.
Yeah.
And it's something, everyone's happier at our house. And
Josh is going to be like replaying this
and I would miss it.
Yes.
If it was gone.
Yes.
It wasn't like this overnight thing for me where I just had this sudden loss. So many of my patients were coming in being like, no, 5 years ago, it was great.
Yeah.
And I love him. We talk about relationship disorders. We talk about orgasmic disorders. We talk about arousal disorders. If you can rule all that out, it's pretty much hypoactive sexual desire and pain, of course. If you have pain, no one wants to do it, and we have to fix that.
Yeah.
So, yeah. So I was like, it feels so good to be able to talk to patients about it and be like, I'm not talking chandeliers or I'm not 23 again, but there's definitely more interest in the area, and it's made things better for us.
I love that. I also really admire and appreciate you were talking about your meno-posse.
Yeah.
And so tell us about what that means.
So welcome to the Metaverse, which you are now our honorary member.
Yeah.
And the meno-posse is the name of our group chat on a message chat through iMessage. And it's a collection of healthcare providers, doctors and nurse practitioners who have focused their practice on menopause care. And these are the women I meet at these South by Southwest. I leave tomorrow, and we all share research articles back and forth. We support each other on social media. I called Corinne Menn, who's a breast cancer survivor. I had a breast cancer survivor. I had a quick question about a patient. How do I direct her, and we're just always there and available for each other and so supportive and bringing each other to conferences and like sharing the latest information. And it is the greatest group of women. And we have Avram Blooming wrote and Carol Tarvis wrote Estrogen Matters. And so his daughter does all his social media. I call it a few good men.
Yeah.
And so, we kind of have this amazing collection because you feel really alone. When I started doing this, I felt alone. And I didn't feel like anybody else, because you don't know what the algorithm shows you on social media. And I didn't know anyone else was talking about this. And then, boop, there's another one, and there's another one, and there's another one. And so it's been this really wonderful thing because it helps me get through this process, because there's so much backlash. There's so much pushback. There's so much of the medical establishment, which really was designed to help the basic white man, and there's multiple books documenting this. Every woman knows she's been gaslit at the doctor. She's been dismissed. She's been ignored. And something, gynecologic pain is another huge thing we need to address. And so, knowing that I've got the posse behind my back and we're all going to stand together and support each other. And we don't all agree 100% on everything, but, knowing that there's this respectful, kind, generous group of people who all have the same goal as the health of women, different than women's health, right? Women's health sounds like reproduction and birth control. The health of women is like us all aging together as healthy as possible. I call it my nursing home prevention program.
I love this. My best friend and I, all the time, we talk about the scenarios because we're like, look, statistics show it's you and I. Like that there's a high chance that if we fast forward and we're both blessed enough to be here, like, what are we going to do? And we literally talk about our plan. So I am so on board with this. And I was thinking to myself, like, how powerful that is and how grateful I am for the work that you're doing and for the menopausal, because we need to take better care of ourselves and take better care of women, because nobody's coming to save us.
Right.
And so we need to do this, because I plan on being around for a long time and I don't want to be frail. I want to be strong. I want to go for as long as I'm blessed to be here. I want to be as spicy and as saucy and as strong as I possibly can to keep doing the work that I love to do and to keep living an amazing life.
And we are uncovering those strategies that work for most people that will decrease that risk.
Yes. You know, I want to read something before we wrap, and I want to ask you if there's any one message you want to leave women with, but this is just something beautiful that you wrote in an essay. So I'm going to be reading your words to you. If a woman in perimenopause or menopause isn't getting top-notch care, it's a matter of life and death, really. There are issues that many women are attributing to getting old while they scramble to be believed, get help, and thrive during what should be a powerful and exciting time in their lives. You are not a whiny woman. You are not crazy. And no one, especially your healthcare provider, should make you feel as if you are. You don't have to take it anymore. You have options for treatment and care. Tearing up reading this. You're a person who deserves a beautiful, healthy menopause, one that's filled with strong muscles and bones, a clear mind, and a body free from pain and disease.
Yeah. And that's not happening today. My grandmother spent 5 years in a bed at the end of her life. And she didn't want that, you know, and she didn't know the tools that might have been available to her to prevent that.
If there was one message that you'd want to leave our audience with, what would that be?
That menopause is inevitable and it's a natural process, but suffering through it is not.